Cheryl Treadwell, and welcome to the Family First Prevention Services Act overview. We will providing you an overview today in this webinar of the Family First Prevention Act Services Part 1. And before I get started today, I wanted to introduce that I am sharing my presentation with a panel of folks and presenters. I'm Cheryl Treadwell. I am the Chief of the Safety, Prevention, and Early Intervention branch here at CDSS. I will be presenting along with Kelly Winston, who is also a bureau chief in my branch. And in partnership today, we have a representative from the Department of Healthcare Services, Linda Dorsey. So we're happy to have her here in partnership for our presentation today. So I will get started. So as I said, we're here today to talk about FFPSA Part 1. Part 1 for FFPSA creates an optional program for the state to receive 4E reimbursements for the availability of prevention services so that we can serve children who might be at risk of imminent risk of entering foster care and provide supportive services to parents, families, and caregivers. So in our presentation today, we will be discussing our progress with implementation, reviewing our vision for our comprehensive prevention services. We'll be looking at the enabling statute that was implemented here, that was legislated here in California, AB 153, that enabled and codified the federal statute. We will be stepping through a little bit of the prevention plan, the 5-year prevention plan that was submitted to the feds. And then we will outline a little bit about, and at a very high level, about the funding sources, talking about specifically when counties might be able to claim for prevention, and looking at our funding sources at a glance, because they're in combination with the state funding and with the federal funding, there is resources available to build the capacity for implementation. We will talk about the maintenance of effort, a look at the payer of last resort, and finally, just summarize at a high level how our guidance timeline, what our timelines for guidance looks like. Next slide, please. As mentioning, the vision for the prevention services in California involves the integration of the whole child and whole family, whole community approaches. Go to the next slide, please. In doing so, we feel like California has several initiatives that strategically line up to expand and build out our comprehensive approach to implementation for prevention services, such as we have our Office of Child Abuse Prevention Strategic Plan. That plan in itself promotes the holistic safety and well-being of children and families by building capacity to support more families under FFPSA, by linking more of the public and private entities that share a prevention agenda, and the ability to leverage the resources through our community and natural supports. Expanding on that plan aligns with our prevention-based approach. Then there's the Indian Child Welfare Act. We've codified it here in our state. It's a federal statute. And through our state law, we're able to articulate to counties and caseworkers how to handle Indian child welfare cases. Focusing on how we integrate ICWA into our prevention continuum, focusing on building our requirements around active efforts, inquiry, and notifications to make sure that we engage tribal families in a way that we prevent interest into our system. It allows us to address the disproportionality aspect of that and be able to strengthen the aspects of Indian families. Then there's the continuum of care reform. It was designed to reduce the reliance on group care. Um, the continuum of care reform focused on also shifting the focus to permanency and providing safe and nurturing homes for children and youth. Um, then there's our Systems of Care initiative, which was enabled through legislation that we are commonly referring to it as AB 2083. It was also enacted to build out a systems of care approach to approach serving youth and families in foster care, in the foster care system, along with our partners. It requires counties to initiate an MOU. We have an MOU at this model MOU at the state and the county levels to conduct an analysis, determine the gaps in terms of placement of services, build out a full continuum in terms of system of care. So that aligns well with building out a system of care from a prevention framework perspective. Then there's the integrated or practice model adopted at the state and county agency level. It offers an integrated and standardized way for families to be engaged from the practice perspective, making sure that we also continue to focus on trauma-informed engagement, strength-based approach for the child and family team aspects. Then FFPSA, of course, is an overarching piece to all of this. It presents an opportunity for us to help build California's full continuum for a comprehensive prevention systems of care approach, one that is more holistic, one that is very strength-based and equity focused. Next slide. As I said, it's an integrated statewide system approach. One of the things that we want to emphasize in this approach is that we want to support the social determinants of health in building our framework. I listed here, what's listed here on this slide, as mentioned earlier, is that our vision is achieved by making sure that we lift up family voice and others of lived experience, focus on racial equity, making sure that we're engaging and consulting and collaborating with the tribes, being trauma-informed and strength-focused, and above all, making sure that we're monitoring the integrity using a continuous quality improvement approach. I will now turn it over to Kelly, and she will take the next segment of this presentation.
Thank you, Cheryl. So Cheryl's talked a lot about the vision of this program and wanting to make this a more comprehensive approach to prevention, but I'm going to focus a little bit on what FFPSA Part 1 requires in order to provide that Title 4E drawdown. So due to the narrow focus of FFPSA, only those at imminent risk of foster care, so in other words, tertiary prevention, and only those services approved by the Federal Prevention Services Clearinghouse can be included in the state's 5-year prevention plan. There are many requirements for providing prevention services under FFPSA, and that they must be evidence-based and that states develop a continuous quality improvement approach to evaluating the delivery of those EBPs. Additionally, states are required to share how expenditures are used in program and to provide data for child and family specific outcomes. But despite these limitations of prevention services, focusing solely on those rated in the clearinghouse and aimed at tertiary preventions, this continues to be a really important law, because it's the first entitlement program for prevention services, particularly for those children and youth or caregivers who typically don't qualify for or who have already exhausted other benefits and find themselves on the doorstep of the child welfare system. We really do see this as an opportunity to strengthen best practices by aligning prevention services with active efforts required under the Indian Child Welfare Act. This law also opens the door for providing a CQI approach to developing and providing prevention services, which we haven't been able to do in the past. It's going to help us evaluate prevention outcomes essential for the future of child welfare system improvements. As Cheryl said, we are opting into this program, and we've done that through the submission of a state plan that has already gone to the Administration of Children and Families as of August. And it details how we'll implement the program and comply with all of the requirements, which we're discussing today. We are in the process of awaiting feedback, and we anticipate that feedback and potential questions coming from ACF as they complete their review. Next slide, please. So I'm going to talk a little bit about AB 153, which codifies the statute into state law. So next slide. So earlier this year, we codified this, this program into California law as Assembly Bill 153. Under this law, there were new requirements reflecting mostly federal law for the development of a prevention program. Specifically, AB 153 added new Welfare and Institutions Code sections for establishing the Part 1 prevention program. Requirements of FFPSA prevention services under these new WIC sections include eligibility for prevention services, qualifying prevention services, and prevention plan requirements. AB 153 additions also include the state's commitment to consulting with counties and tribes in development of the state plan, requirements for delivering and reporting on individual prevention plans for local jurisdictions, and further clarifies the program's requirements for eligibility. So a little breakdown, WIC section 16585 is the section that affirms the state's commitment to the implementation of a comprehensive prevention services program in order to reduce foster care entries and to keep families together. WIC section 586, this section provides all of the key definitions and terms that are used throughout the program. 16587 specifies the requirements for counties to opt into the program by submitting a local plan that would be developed in consultation with all of the relevant entities. And it requires CDSS to consult with Indian tribes on the statewide prevention plan, any associated allocation policies, and a process for a tribe who operates a 4E program pursuant to the state agreement to opt into the prevention services program. This section further provides that Family First prevention services can be offered up to 12 months, including additional and/or contiguous 12-month periods on a case-by-case basis, as long as the child continues to meet the requirements to receive those services. WIC section 588 specifies requirements for utilizing state and federal 4E funds, and then 16589 explains the CDSS requirements and commitment to collaborating with the Department of Healthcare Services. This will include producing joint guidance on payer of last resort requirements and coordination of Medi-Cal services and payments. Next slide, please. So again, the narrow focus of FFPSA includes only those children at imminent risk of foster care and only those services that are included in the Prevention Services Clearinghouse. Some additional requirements for these services are that service delivery must be trauma informed. There has to be ongoing continuing evaluation, ongoing demonstration of model fidelity, and it also specifies that Title 4E is the payer of last resort. We've said this before, we are opting into this program. We have submitted our plan to ACF, and that plan has included who will be served, what services will be provided, and how California will meet the requirements. There will be lots more additional department guidance that will be submitted and shared with our stakeholders in the coming future. And we're going to talk a lot today about those timelines. And I'll hand it back to Cheryl to talk a bit about the prevention plan.
Kelly. Next slide. So as Kelly said, we submitted our 5-year prevention plan in August. Listed on this slide outlines the categories of how our prevention plan was arrayed and arranged. But I want to speak a little bit about how the feds basically describe the minimum requirements of what we were required to do. The state had to describe how we would do oversight, how we would assess children and families. The state also had to describe what the evaluation strategy would look like, um, which includes maybe a cross-site evaluation approach that has to be approved by ACF. We had to describe how we would monitor and oversee the safety of children and families during that 12-month period, and be able to determine what that risk and safety would look like on a periodic basis, how we would re-examine that through the child's prevention plan during that 12-month period. We also had to describe how we consulted and engaged with our other state departments, like our partner with healthcare services, and making sure that we are coordinating those services that may fall under the other health programs. Um, and also making sure that we align what we do with our Title 4B plan, making sure that the workforce is addressed, making sure that there's training for the workforce, and then describing what our prevention caseloads would look like. We did a lot of that work with a robust stakeholder process that many of you on this call participated in. So we'll be describing later in the presentation some of the highlights on some of these areas in our plan. Go to the next slide, please. So I wanted to highlight and lift up especially the area around prioritizing equity and inclusion for our department. That is a very, very high priority and commitment. And given the climate of the country and where we've been in terms of our engagement and experiences with communities of color, we want to make sure that in our approach to prevention that we are having a meaningful approach and impact to that. Focusing on, of course, the disproportionality with people of color, Native American, the LGBTQ plus community, and making sure that in our integrated core practice model that we adapt with respect to the equity and inclusion approach. As I said, making sure that things are trauma informed, that we're able to examine and incorporate cultural adaptations to the evidence-based programs that we are selecting, and making sure that in our community and tribal pathway, that we're able to provide access to those services, as we said, prior to the creation or referral to our system. So those are critical. That is a really critical high priority for our area, for our implementation of prevention services that was articulated in our plan. The one piece that people may or may not know that we added to this was that in our department, we have an Office of Tribal Affairs and we have an Office of Equity that will be partnering with us to help make sure that we are staying on track with that focus. And then I will punt it back to Kelly, who will talk about other areas of the plan in terms of eligibility.
Thank you. So this next slide really talks about our approach to determining eligibility, or is what many people hear us commonly refer to as candidacy. So federal guidance defines a candidate as a child who's been identified in a prevention plan as being at imminent risk of entering foster care. You're going to hear that a lot. But then this child who can also remain safely in the child's home, given that they are provided prevention services to prevent their entry into care. With this definition, states can determine what imminent risk looks like in their own communities and must identify who will be served through FFPSA in the plan. So following lots of consultation with counties, tribes, community-based organizations, as well as those with lived experience, CDSS has determined that a child or family that falls within one of these categories of circumstances would likely be considered eligible for FFPSA following a further determination as to whether or not the child within that category is assessed at being at imminent risk for foster care. While the categories of circumstances on this slide are considered eligible for FFPSA, they're not a comprehensive list. And even within these categories, candidacy still must be determined by an assessment that assesses for that imminent risk. The department also intends to develop or adopt a tool that will help counties determine what that imminent risk looks like, and to be able to document that for individual prevention plans. Because imminent risk really has to be determined on a case-by-case basis. So we want to ensure that thoughtful consideration for each child and the change in the family's unique needs and circumstances over time. And we want that tool to assist in us having an unbiased process, so that each family is considered with their unique experiences and also with the same type of lens. So prevention services are voluntary for pregnant and parenting youth, and the children of pregnant and parenting foster youth should not be subject to those same formal risk assessments when prevention services are provided, given their parents' categorical eligibility for services. So while we talk about the candidates for foster care and that imminent risk being required, the pregnant and parenting youth in foster care don't have that same requirement. And so we want to make that distinction here. The services are, this group of youth are eligible for services, but don't have that same imminent risk requirement. And then finally, I mentioned this earlier, but candidacy can be completed initially in every 12 contiguous months. So, you know, a family can participate in services for 12 months. If we find that they're still eligible, another 12 months can continue to be provided. A county may contract with another agency or community-based organization for specific case management activities, and we'll be putting out forthcoming guidance to clarify what that process looks like. We want to clarify again, however, that only the Title 40 agency can conduct the determination and documentation of candidacy and eligibility for services. Next slide, please. So we recognize that expanding access to trauma-informed evidence-based interventions can lead to fewer children in foster care on the condition that safety and well-being of children remain that highest priority of local 4E agencies. California will allow local 4E agencies to utilize the following pathways to identify, assess, and support a child or family with 4E funded prevention services. These pathways are a community pathway. So a 4E agency can connect with a family resource center or another community-based organization to complete a strengths and needs assessment and gather information for the 4E agency to determine candidacy. After the candidacy determination has been made by the local agency, the FRC and CBO will be notified that the child, youth, and family are eligible for FFPSA Part 1 prevention services and can develop the prevention plan that will then be approved by the 4E agency. Local 4E agencies ultimately retain the responsibility for supervising 4E prevention program activities and ensuring that all the requirements are met. A county probation or child welfare department can participate in the Title 40 agency pathway. There are multiple ways in which local 40 agencies can identify, assess, and support families with prevention services. So a case may come through, or a referral may come through the child abuse hotline. If an investigation is initiated from child abuse hotline, a child abuse hotline, that can result in a substantiated or inconclusive finding, but yet maybe a case is not yet open. A child may be identified as a candidate based on an appropriate assessment for prevention services. What we typically see as an existing family maintenance case is also eligible for prevention services. FM services can occur to prevent entry into care and may be provided after reunification to prevent reentry. The FFPSA provides an opportunity for child welfare agencies to develop or expand capacity of existing FM programs. And probation officers may also conduct assessments for candidacy, but would need to individually opt into FFPSA and partner with local 4E agencies to provide those prevention services. I'm going to pass it back to Cheryl to talk about the tribal pathway, which is a little bit different.
So the tribal pathway is not in itself necessarily a separate pathway, but it was our way, the way this slide is depicted, to sort of describe how the process for engaging Indian families in the community and also in the community pathway, and also how it worked with a 4E agency pathway. The tribes with state 4E agreements may establish their own Title 4E prevention program. The caseworkers there will have the discretion of determining how best to assess for imminent risk. But basically, Indian families that are not under the responsibility of a tribally operated 4E prevention program, they will have to receive their prevention services through a local 4E agency that opts into the state's prevention program. Those local agencies must inquire whether a child is referred to the hotline. They must follow the ICWA requirements. Inquiry, notification, active efforts should be infused in that 4E agency's process, as well as in the community pathway. So it is just an emphasis to bring in what ICWA requirements are into these two pathways to make sure that it's occurring. That's basically our way of just re-emphasizing the need to lift up the tribal engagement and priorities. So the department is committed to ensuring that that consultation occurs with supporting tribal interests. We articulated that in statute to make sure that occurs. So I think that is a demonstration of our priority of this area, and we will be working very closely with tribes on engagement in terms of further guidance about how this would work. Next slide, please. So as you can see here on the selection of evidence-based practices, we selected all of the evidence-based practices that were well supported. That entitles us to 50% support from the feds on well supported, and allows us to really get into implementation easier because of the fact that we don't have to get into evaluation of those practices. So that provides a tremendous cost savings to us to not have to do that because these have already been rated by the Federal Clearinghouse. So these services must be delivered by a qualified clinician, but clinician in this context is a professional who's able to meet the standards of the evidence-based practice model. It is not the qualified individual that is discussed in the Part 4 presentation and requirements. I want to make that very clear. It is a very separate definition when we talk about a qualified clinician. And then we talked about the ability to have adaptations to EBPs to increase the cultural relevancy of the program. So we made sure that we included that in our plan. And as you can see here, we just sort of laid out what the state requirements are and how that was articulated in our state law and in terms of the way we're approaching it as well. It's very consistent. You see the list of EBPs here. It is our hope that counties will consider using the state block grant funding to help support the implementation, maybe moving the promising and supportive programs so that they can be included in their comprehensive services plan. So we'll have more discussion about what that statement means. Next slide. And then, of course, there is the data evaluation and the continuous quality improvement piece. As you can see here, what we laid out is the risk assessment frequency, what we're required to report. We have to report the specific services on each child. We have to report the expenditures associated with those services, placement status, and we have to design a cross-site evaluation for if we choose any promising and supported practices for the feds to be made aware of. We codified that in state law. Kelly talked about that earlier. But our goal is to align all of the work under a robust CQI process, so we can integrate that starting through our automation process, figuring out what those methodologies look like to monitor fidelity and quality on our practices, how that works with providers, how we facilitate outcome evaluations to figure out whether or not those services are meeting the goals of the families. So we have a lot of work to do, but this is really exciting in terms of finally setting that baseline for a very great CQI process.
Okay, so next we're going to talk a bit about the Part 1 funding sources that we have available. So next slide, thank you. So this slide gives an overview of our newest prevention funding streams. In addition to the existing prevention funds that have been available for quite some time, this slide talks about what can be used to help develop the local plan for prevention services. And when I say that local plan, I mean that comprehensive approach. So in the first column that you see here, we have the FFTA, the Family First Transition Act funds. This is a federal grant of about $49 million that has already been released to counties. These funds will support implementation of FFPSA and other prevention activities. A portion of these funds, about $5 million, were retained by CDSS to finance the development of statewide standards and processes and other tools that can support that coordinated approach to prevention. At least 50% of FFTA funds must be used for prevention and early intervention planning, expanding capacity for evidence-based practices, FFPSA evaluation activities, and transition activities for former waiver demonstration project counties in order to transition to FFPSA prevention services. FFTA funds will be available through September 30th of 2025. Funds will be available for counties must declare their intent to receive these transition grant funds by submitting an attached letter of intent by October 31st of 2021. And let's see, the second column here talks about the general fund block grant. The budget includes about $220 million in general funds. It was included in the 21-22 budget year and can be expended over 3 years to assist counties with new prevention services implementation efforts allowable under the new federal FFPSA. These one-time resources can be spent over those 3 years, available until June 30th of 2024. The third column is the American Rescue Plan Act Community-Based Child Abuse Prevention Funds, or CBCAP. CBCAP is utilized by counties to strengthen and support families to prevent child abuse and neglect. It's primarily used for primary and secondary prevention efforts, and can be used to address structural issues that contribute to becoming involved in the child welfare system. It can be used to advance racial equity and to provide support to families and communities historically underserved or marginalized by child welfare systems, while ensuring the safety and well-being of all family members. The ARPA CBCAP funds are available through September 30th of 2023. And then finally, Title 4E, again, this is the first time we've been able to use 4E funding to support prevention services. This requires child-specific claiming information to receive 4E funds. And as such, we need to develop automation to be in place prior to claiming. Otherwise, we will struggle to be able to include all of the information that is expected to be reported to the federal government. As our current system, CWS-CMS, is not able to collect that. So we are in the process of developing that automation, and additional guidance regarding that will come out soon. Next slide, please. Okay, so many folks have been involved in calculating this maintenance of effort information. So the federal government requires that we maintain the level of prevention spending that we had in the base year that they've identified as 2014. So all evidence-based programs, we had to collect information about what was in place during the year of 2014. And counties worked with us to identify the services that they were providing at that time that met this criteria. So it had to include all evidence-based programs that were trauma-informed and delivered to model fidelity to candidates of foster care at that time in 2014. And the services had to meet specific criteria. So the questions we asked counties were whether or not the county was delivering a service rated in the clearinghouse in 2014, whether it was delivered to candidates for foster care or pregnant and parenting foster youth or their parents or kin caregivers. The term candidate was defined in ACL 1436 and Section 8.1D of the Child Welfare Policy Manual, which includes populations such as court-ordered family maintenance, voluntary family maintenance, and probation candidates. We also asked counties whether or not the program was delivered to model fidelity. And if the answer to all of these questions was yes, then we calculated the total spent on delivering those services to candidates. If the county didn't have that child-specific funding information, then we used, basically we calculated a percentage of candidates to the total population served and applied that percentage to the money spent on delivering that service to their population. So after all of that information was collected, the MOE estimate that we had in California was $2,693,557. And we submitted that information with the Title 4E 5-year state prevention plan when we gave it to the feds in August. We're currently working to develop a methodology and guidance on how the MOE will be released in coming months and how that burden will be distributed across counties. Okay, a little bit more on automation. So as I mentioned, opting into FFPSA means that we have to have a way of tracking all of the activities required in Part 1. So a little bit about child-specific tracking. Under FFPSA, it's required to capture child-specific data for reporting outcomes from service delivery for each individual child and family service. This includes data that involve the duration of services and programs provided, expenditures, and placement status. Additionally, capturing child-specific data through automation is essential for developing invoicing structures for ease of claiming for 4E reimbursement, as CWS-CMS doesn't currently provide this capability. We also have to track evaluation. The state must also report information through the state plan on the specific practices that we will use to provide services or programs, including a description of how each service or program provided will be evaluated through a well-designed and rigorous process, unless, of course, we provide a waiver that is approved for a well-supported practice. Automation can assist in standardizing the data collection process and to help us set a baseline for future evaluations. Model fidelity is another criteria we must collect information on. So automation can allow for collecting that ongoing data for ensuring that services are provided in the way that they are intended through the model fidelity of each EBP. This includes standardizing how EBP specific domains and services are captured, and includes, but it's not limited to, EBP outcomes, outcome domains, and other assessments. CDSS is currently working on automating this process to streamline the reporting and tracking information and data to monitor model fidelity and evaluation of services. The development of an automated system within CWS CARES also allows for the reporting of federal requirements of child-specific data to assess child and family outcomes, along with submitting child-specific data for invoicing expenditures. Additionally, the prevention services inventory that we will be asking counties to submit data on will help the state report well-supported services and add others in the future for a comprehensive provider network. Okay, payer of last resort guidance development is all Cheryl.
Yes, so basically it says that before Title IV can pay, if a private health insurance entity or a Medicaid can pay for the service, they should pay for it first, and 4E is the payer of last resort. So we have started working with our partners at DHCS to start delving into identifying what potentially Medi-Cal eligible services might be part of the EBP subcomponents. So we're starting that work now, and I'm sure there'll be some further reach out and engagement with our provider world and county world to get more insights on this area as well. But I will, we'll be working on joint guidance at some point in the future. So for the next phase of this, I'll turn it over to Linda Dorsice from the Healthcare Services that will talk about this next segment.
Thank you, Cheryl. And thank you to the California Department of Social Services for the opportunity to co-present on today's webinar. The Department of Healthcare Services is pleased to be working closely with CDSS on this important initiative to improve the health of some of the most vulnerable children and families in California. As mentioned, DHCS is collaborating with the team at CDSS to identify the role Medi-Cal can play in the Part 1 prevention program implementation. Federal Medicaid reimbursement may be available for prevention services if all state and federal requirements are met and the treatment is medically necessary. Both departments plan to collaborate to develop and issue joint guidance regarding services and activities that may be Medi-Cal reimbursable. Next slide. Several of the evidence-based programs included in the Part 1 prevention program have subcomponents that are existing specialty mental health services. And those subcomponents may be Medi-Cal reimbursable as long as all Medi-Cal requirements are met. For example, what you can see on the slide here are 3 examples of well-supported EBPs that CDSS is including in their prevention program, which are in part or all currently reimbursable by Medi-Cal under the Early and Periodic Screening, Diagnostic, and Treatment Services Program, or EPSDT. Those EBPs are functional family therapy, multi-systemic therapy, and parent-child interaction therapy. And as I already mentioned, additional guidance from the departments will be forthcoming and will hopefully clarify a lot of what we're talking about today. And now I hand it back to Kelly or Cheryl to walk us through the anticipated funding and guidance timeline. Thank you.
Thank you so much, Linda. So this just provides a snapshot at a glance look at our timeline. Some of the things were alluded to earlier in our presentation. You know, the funding's out for the FFTA funding, data reporting requirements, federal requirements for reporting the letter of intent. So we have a very pretty much compressed timeline. If you look here, what needs to be provided between now and the end of the year, what needs to be coming from us between now and July of 2022. Just trying to highlight to you where you see the counties in July of 2022 should submit their comprehensive prevention plan, and then the anticipated release and ability to draw down 4E matching funds somewhere anticipated between July and October. A key point to remember is that the automation requirements, we're really trying to work toward nailing that down soon, because that is very critical to be able to meet our anticipated ability to allow counties to draw down the 4E matching funding. Next slide. So here's another snapshot, sort of how we see our next steps, finalizing our entire approach with stakeholder engagement, of course, to implementation, our communication strategy in terms of how we will continuously communicate, developing the guidance on all of the things that we've been talking about through the presentation. We certainly want to leverage any existing groups to address the areas around what type of risk assessment tool we would use, how we're going to build CQI, what the elements of the comprehensive prevention plan should be. It is our hope to convene what we call implementation collaboratives, be able to provide technical assistance, a lot of work this year that we need to complete. And then looking forward to 2022 next year, establishing our baseline and readiness question, answering that question, are we ready to implement? Making sure our automation is in place and that we're able to capture how services are delivered so that we can claim. And of course, providing guidance around these areas that we have mentioned before in our presentation around data collection, CQI, and workforce development and training. Next slide. Here's our contact information. Feel free to submit any questions. We know we threw a lot of information at you today. Look forward to working with a lot of our stakeholders. We'll be mobilizing our resources. What you got today was a big picture of Part 1 FFPSA. There will be more webinars, a lot more other support, TA supports that we will be offering. And I would like to say on behalf of the departments, DHCS and CDSS, we appreciate all of you that have been involved in our engagement process early on, and we look forward to working with you in the future. So this ends our webinar.